Vanakkam Chennai, a very good morning. Before I express my deepest gratitude to the whole CECCRe team, especially Muthu sir, I would like to take a minute to thank the city of Chennai. Chennai has been very, very kind to me, especially because of Muthu sir and various other respected seniors. Right from 2017, which was my first ever national lecture, just back from the fellowship. It happened in 2017. I was back in Chennai multiple times in 2018 for some keynote speakers, keynote lectures. And 2019, we got the Best Paper Faculty Award in ISDT. Been invited during COVID times to Meenakshi Ammal. Sir invited for the special contribution, the special care dentistry chapter. This year only in the morning, early year, we were for the convention there. Got the opportunity to attend GA with Sir. Have been associated with CECCRe in some form or other form. So deepest gratitude and heartfelt appreciation for all the support for now, and feel proud and privileged to be part of CECCRe in some form or other form today as a resource person. Without wasting much time, let's begin the sessions in the most timely way. As the topic suggested for the today, it's a checkerboard of SECC in young toddlers. The interplay between black and white. This is a purely clinical lecture. In 15-20 minutes, we would like to purely talk about the clinical experiences which we have shared over the years treating SECC. This is something which will probably switch you over the illusion of black and white. So let's go for the ride. Before we begin, it's important to announce that this is a conflict-free lecture. This is non-sponsored lecture, and everything which is shown is our own cases done in our practices. The 15 minutes tool is to learn and pick up anything, but this is something which probably you know about it, but it's important to discuss in an important scientific platform like this. So 15 minutes is more about introspection. Now, SECC, as we know, when in very depth and detail, is something which starts as early as first year of the life, and be it 12 months, 14 months, 18 months, 2.5 years, 4 years, 6-7 years. This is catastrophic, and this can be something which is we call as very unforgiving. So this is an everyday story of pediatric dentistry, and these pictures are unfortunately not from Google. This is all recorded by us in our day-to-day practice, and this is what we are trying to correct in the form of correct the black of SEC with the help of white of zirconia. We are fortunate enough to see the growth and the invention and the implementation of zirconia crown right in front of us in the last decade. And now we all know there are so-called global companies which are providing this care to us, especially the CHECHKERBOARD crown from our very own Dr. Mukul to New Smile and to everyone else. So this is something which is a proven thing. Just trying to highlight that this is something which we have been using for a while, and we have a fair amount of success, especially when we talk about anterior teeth. Posteriors, there are certain debates regarding the maximal invasiveness, but in anterior, if we see, overall, this has given a gold standard outcomes. Even in posteriors, we have tried, but again, it's something subjectively we can use in our patients. So these are the pictures where we have used zirconia crowns, pediatric zirconia crowns very, very effectively, and we had good long-term follow-ups, be it 5 months, 1 year, 1.5 year, 2 year. We see the stability and the longevity, plaque-free restoration, and nothing comes close when we come to full coverage restoration, especially for anterior teeth. Now, the idea to highlight is that these zirconia crowns have been always available to us, but each one of us who does it understands that this is not exactly a minimally invasive, but maximally invasive pediatric dentistry. And in certain cases, our heart goes out that do we really need to do this, because it means loss of so much of vital structure. That's where the next interplay of black and white comes, which means to cover the maximal invasiveness of white of zirconia, we had black of SDF. Now again, fortunately, this has been a very important tool of our armamentarium in the last 5 to 7 years, especially in India. We don't need to talk about SDF. I think all of us are very well versed about it. How the silver diamond fluoride is one of the major cornerstones of minimally invasive pediatric dentistry. And in certain cases, if we see like this, when there is a good amount of enamel structure, we feel SDF do wonders. When we have long-term clinical pictures of these anterior teeth, what we see very specifically is that not even a speck of extra enamel or degradation is there. So it's a very clear documentation which says that SDF not only arrests the decay, but it hardens the enamel. it strengthens the enamel and makes it much more resistant to further decay. We can see this that even at a 1.5 year follow-up, there is no further involvement, not clinically, not pulpally, not radiographically, which is an immense success. Yes, we can obviously crown the posteriors because of the mechanical wear, but anteriors in these cases, we are good even at 2 years follow-up, and then further based on child's cooperation, like this child even after 2 years couldn't get a very good cooperation, we could cover some amount with the strip crown, and it gives a reasonable amount of clinical outcome. Now, but in certain cases, when we have already some loss of structure, remember these cases are all from 2, so I haven't mentioned the age per se, but these are all 1 to 3. We are talking about toddlers and preschoolers. And there is already a lost structure, especially later incisors because of the lower size. Now, we need to be mindful that despite we are doing MIPD, minimally invasive dentistry in the form of SDF and Hall's crown in the posteriors, these lateral incisors or these tooth keep on getting wearing off. And this is what we are trying to talk about, that although we have got a very good arrest and clear demarcation between the hard enamel and the original enamel, the structure keeps on getting lost, especially when the parents have come very early, the child is too young age, or the structure was already at the loss because of mutilation or masticative forces. So even at 80 months follow-up, this seems to be fine in terms of holding it up, but will it hold up for the entire duration is a question we are asking today. Even here, if we see the anteriors, we see that eventually these teeth get non-vital or get worn out, and we probably have to extract them. Now, again, we are showing certain cases where we see there is further more destruction in the anteriors, and despite we want to stick with MIPD in the form of SDF, the longevity of these teeth comes questionable. So at 3rd month seems to be okay. At 6 months, we clearly see that the structure is getting lost out. And despite we have a very good follow-up and trying to maintain the follow-ups, we put the crowns, we put the restorations, we put some smarts. We lost the front anterior, the 5161, because of loss of vitality and maybe possible clinical abscess. Again, what's the prognosis of 5262 at 1 year? That's the question we are trying to ask today, that despite we are trying to be minimally invasive, will these structures last the entire duration? So at 22 months, we know this tooth is not going to last. It's already non-vital, and it's a matter of time if we extract it or the parents come symptomatically to do. Most importantly, how will this canine last? That's again, we are trying to ponder over here. Again, a 2-year-old with even certain good amount of enamel, and this is something which we can also think as a researchers, that despite putting the same SDF in the similar scenario, some SDF really hold up well, but some of them eventually goes down the drain, despite putting the same material, same protocols, same situation. So the question is, will these teeth hold up on its own till the time the child gets cooperative, or parents need aesthetic demand, have aesthetic demand, or for that matter, if we feel that this is the right time to preserve the tooth. So again, all these cases simply show that despite immediate post-op, you see there's a good amount of loss of structure, and this is majorly due to masticative forces and maybe the ongoing mutilation already happening. But that comes to the very important interplay of how to control this plaque of loss of vitality and structure of SEC. So now we actually go back to the Hall's technique of white of zirconia. Let's see some cases to understand what we are talking about. Now, in certain cases in the last couple of years, what we have started doing is that the moment we see a child with SECC, we obviously try not to avoid, but to reduce the pharmacology, either under oral sedation or nitrous or under restraint. We do SDF and hold on the decay, do the ICCMS and the CHECHKERBOARD guidelines, change the environment, change the approach, change the oral hygiene habits, and hold on the enamel. Now, after 5 months or 7 months, we see that centrals are holding up, but the laterals are not. And that's where when we give the offer to the parents, some parents, because of the social background, the school background, the peer background, take up the preservation of the structure by the help of zirconia crown. And if you see from 20 to 35, this is now from a young less than 2 to almost 3, we were able to manage. And the most important part is all these crowns are vital. So we're not talking about doing any non-vital pulp therapy, pulpectomy, or for that matter, anything invasive. We might still have to use oral sedation, but then at the end, we are able to do this in the form of Hall's technique with only crown preparation and no caries preparation. Similar in this case, these are 3-year-old treatment evaluation. If you see the pre-op picture, see the radiographic picture, put them on SDF, found time for 6 to 8 months, and after almost a year or so, we do this zirconia crowns, which one of the tooth like 6-2, we had to go for non-vital pulp therapy just to eliminate any chances of retreatment. The rest were all vital. So again, we had a mom from dentist mom background coming a little further, 50-70 kilometers away from us, have the SDF. Now what's important to see is that despite this looks pretty fine and good case for SDF application to avoid pharmacology in young toddlers, very early, within 6 to 8 months, we see the loss of structure, especially in the laterals. And again, even after passing 1 year, do we expect this teeth to last for another 2, 3 years, 4 years? Is one. And in the moment when parents have expectation that let's try to cover it up, we do these vital zirconia crowns without doing any non-vital pulp therapy, which is a very pleasing outcome, not only for the child, but also for the family, and overall increases the social confidence. Similarly, we had medical parents, anesthesiologist father, pathologist mom. Again, the pre-op picture, similar presentations, nothing radiographically, put some SDF. 6-1 looks pretty much borderline for clinical longevity. Put these. Remember, these all crowns are placed not in operating room. These are placed with midazolam oral sedation with minor restraint. And in certain cases, there was fair amount of challenge because we all did all these crowns either in one go or probably like half. And all of them have been vital, and all of them have been doing fine. They're all done in the last 1.5 years. So we are still looking for long-term follow-ups. But so far, so good, whatever we have done till now. Again, clinical picture, if you see the clinical. So what is important to see here is that within the span of 2-3 months, we see the loss of structure despite putting SDF. And here, if we see, we can see that 6 months looks dicey. And then eventually we had to go for non-vital therapy in 5 and 6 months. But we were able to get a very good clinical outcome in the form of zirconia crown within the span of 1.5 years. The last one, again, 22nd October, we did these, we found these SDF treated teeth. The 5-2 seems to be losing the structure, so we had to let go of 5-2. The rest of them were placed zirconia crown and preserve the structure and vitality. My very good friend and colleague, Dr. Mukul, would be further talking about the similar scenarios where now we have something called BioFlex crowns, which is a step ahead of zirconia, which is not hard but flexible and much more biocompatible. I'm sure he would enlighten us much better way. Will be a step forward because some of our colleagues have already posted pictures where these crowns, which will be a much game changer to put this. See, the idea is to give the full coronal coverage in these crowns because no matter how much SDF we do or whatever strip crown we do, the loss of structure would happen because of already destruction going on, and the vitality will eventually get lost. So what's the learning lesson, if you can quickly recapitulate, is that SEC once happened need to be counteracted in the most impactful way. SDF is still our best choice for minimally invasive pediatric dentistry, especially for the toddlers, to arrest and stall the decay. We still need to follow ICCMS CHECHKERBOARD to 2020 and strict sustained anti-infective guidance, coined the term by Dr. Muthu sir, shall help us in keeping the dental review, because that is again a very important part overall to maintain the SDF in the mouth. But a very important takeaway message here is that at appropriate age, behavior, or parental expectation or tooth structure. So tooth structure is a clinical call, parental expectation is a parental call, behavior again is a clinical call. Doing a zirconia or a BioFlex crown like a Hall's technique will help us in preserving the vitality and the remaining structure of this SDF treated teeth. And this interplay between the black and white, we are quite sure might continue in future too as we adopt to newer materials and techniques. I think I hope I have covered the session within 15 minutes. Thank you so much for your patient listening. I'm looking forward to meet everyone in Ahmedabad in the national conference. We keep on documenting these cases on our social media in the form of Instagram, Facebook, YouTube channel. Feel free to watch these cases over the different platforms as per your convenience and comfort. That's it. I think I can take another minute, but just to let you know where do we practice and how do we practice. This is our Snowzellen rooms, we call as losing the senses, sedation adapted dental environment. and we try to have some good time with children, keep providing different stuff. We keep talking about oxys every time when we counsel the children, counsel the families. And just trying to do sedations, spectrum of sedation, special care dentistry, have some good times with the tiny tots, providing them good care, and keep on innovating and finding new ways to counteract the burden of SECC, which is all about CECCRe is taking care. So I think the journey will always be continuing. So glad to be part to share my clinical insight, and I'll be happy to take some questions. Thank you so very much.